You can see my slides?
Yes,
Okay.
perfect.
So it's a pleasure to be here, and this is my first ECHO meeting, and I'm trying to stick with the time so I can go fast with some of the slides, but you have them all. And actually, this is one of my drawings. When I was in medical school, I started to have a developing interest in children and their trauma and interest to decide to become a child psychiatrist. So today we will talk about, I'll try to give you a understanding of this disorder is really to first look at the attachment relationship and its development, because you can actually, after we start talking about it, you can really will see the symptoms of reactive attachment disorder, how they develop through the introduction part. And we will look at the diagnosis, how we diagnose, clinical presentation, and very short epidemiology. Sometimes what else we need to consider, not everything is reactive attachment disorder, and assessment and some treatment interventions that are evidence-based. As we all know that attachment is the organization of behavior that all young child and mammals, they are designed to achieve proximity to be comforted, supported, nurtured, and protected. And the propensity for humans, infants, then really to form secure attachments is so strong that only highly unusual maladaptive caregiving environment can cause attachment to fail. Examples used to be, the literature started with orphanages, but also in our condition, in this country, we have to think about frequent caregiver changes like foster care changes, neglectful and abusive caregiving, or being raised by insensitive, unresponsive caregivers, which could be, we need to think about parents who have mental illness, they can have depression and other like eviction or other mental health problems. And then also in other these situations, young children may really develop clinical disorders of attachment. Attachment has four main functions, and these are really important because the kids that you will be seeing or working with, these areas are most important. Pathology starts from the impairment in these areas. And attachment really provides, first providing a sense of security, which makes the infants and kids secure and having a good self-esteem, security inside to be able to grow and become more independent. Regulation of affect and arousal. I can't tell you how many kids that you see and I see in my clinic that have problems with their regulation of their emotions, expression of their feelings or communication. And also it becomes a base of exploration, which means a step forward to growing, becoming more independent and staying on their own feet. And regulation of affect and arousal is really important. It starts with this attachment relationship. As we know, babies have distressing arousals and they can be in stress for different reasons. And when they are stressed, they send a signal. And attachment is between not only the child's attachment to a caregiver, but it is both ways. It's the caregiver's attachment to the baby, the child, the same way. And if the parent is able to read the signal, the stress signal, and moving to the caregiver or caregiver moving to the infant or the child, this starts to bond, form a relationship, which we call as attachment. It's the attachment relationship between the infant or the child and the parent starts to have this connection and bond. And when the baby is stressed, the caregiver's response, and especially the last box is very important, the parent's capacity to read infant's affect accurately, to provide soothing or stimulation, helps infant to learn to modulate their own stress. And you can imagine if the parent cannot be there or during this stress, babies crying for hours and there's nobody coming, you can see how those kids will have difficulty, how they will learn to regulate, soothe themselves. And regulation on the affect arousal, that's, I think I have two slides on this because this is very important in the attachment disorders and other kids too. Attachment relationship is very important. Over time, we said that this relationship bond with the parent and the child is really is a mutual regulation of the affect, of their emotions, of their stress. And if they are successful regulation of this arousal, this stress together, infant really starts to develop their own mechanisms to regulate arousal, regulate stress. And if the children very early on are learning good self-regulation, the children starts to feel competent in controlling their stress and negative emotions. And that really becomes a very good outcome in even longitudinal studies. The kids who can self-regulate their emotions best, they will have the best outcomes. And if you have an unresponsive or abusive parents, of course, this will promote a chronic hyperarousal and enduring effects on child's ability to modulate or regulate their strong emotions. Also, there's another type of attachment that parent responds negatively. They actually scare the baby, yell, or they can hit, or other ways of reacting to babies crying or stress. And sometimes these kids start to learn in order to keep that relationship, in order to not to upset this parent that they are trying to find security and comfort, they learn to express all their feelings, especially negative ones. And also it's a baseline for exploration. Especially the bottom box is the confidence that the baby or the child develops from this attachment relationship. The children can feel safe to explore and learn new things about the world and develop new skills. And the confidence with which the child ventures out depends on a great deal on their confidence in their attachment relationship. And this is a term, and it's now there's a treatment for it. The circle of security is the understanding of attachment relationship, how this is the healthy part, that how the kids will feel safe, secure base, safe haven. And when they feel safe, they can go and venture and learn and develop their skills and development. And if the secure base is not there, then the kids will be so worried about this relationship, then it will be very hard for them to go out and become independent and secure and venture out to do those things, because they will be stuck in this place, the first caregiver's area, that to make sure that relationship is okay. And if you look at the domains, that if parent is emotionally available, the children will be able to learn emotional regulation. If the parents are warm, empathy, nurturance, they will have security, interpersonal trust. If the parent is able to provide comfort when the child or kid is stressed, they will be then comfort seeking. Whenever they are hurt, they think they're going to go to the parent to seek their comfort. Or if the parent is providing protection, the children will learn self-protection. So if you think about the opposite, if parent is not emotionally available, you will see signs of emotional dysregulation. Kids will have anger outbursts, rages with little triggers. If they didn't have nurtured, warm relationship, they will have a lot of interpersonal negative self-image and negativity, and also difficulty in trust building in their relationships. If they weren't comforted, they may never be comfort seeking. They will always be internalizing and not reach out to any caregiver for help or protection. When they are not protected, they may not be learning to self-protect. And you can see these kids doing really reckless things, reckless behaviors. And I won't tell you about the attachment patterns. There's a lot of literature about that. I'm sure you know. Secure one is the best outcome, and the insecure ones, depending on the type, they may have different outcomes, and especially the outcomes are, of course, not as good as the secure ones. Currently, DSM-5, first DSM started a reactive attachment disorder, and they described inhibited type, disinhibited type. And after studies, DSM-5 changed the definitions. It's under trauma and stress-related disorders, because the causality is the neglectful or traumatic and early childhood experience to create this disorder. And they split it into two. Instead of having disinhibited or inhibited, they made a new diagnosis called disinhibited social engagement disorder, because when they looked at these two groups of disorders, they found different outcomes and different response to treatment. And also in 0 to 3 early child diagnostic criteria, they still use the term reactive attachment deprivation maltreatment disorder of early childhood. So the criteria, actually, some of the things that we already talked about when we talk about healthy attachment, how it develops, you will see that these kids who have the disorder, they are consistently inhibited, emotionally withdrawn, they are persistently social emotional disturbance, they are unresponsive to emotions, limited positive affect that you will see a lot, and they have unexplained irritability, anger, fear, even there are non-threatening environments, and they experience a pattern of extreme insufficient care, social neglect, deprivation, repeated changes in the primary care, which makes it uh, hard to make a good attachment, and also rearing in unusual settings. And the child has to be at least 9 months old, and if it lasts more than a year, if it's not treated, that it can be more persistent. And also criteria is not met with autism, which means some kids who are very high in the autism spectrum early on, at the beginning, they may be confused with this disorder. So it has to be a good differential diagnosis, because they may not respond, they may not seek comfort. Those kind of things can be overlap a little bit. And I want to show you the disinhibited type social engagement criteria. These kids are actively, they are approaching, interactive with unfamiliar adults, and they do it at least 2 of the following. They really, they don't have stranger anxiety. They just treat strangers like that they are family. They don't, when they venture away, they don't look back to the parent. They just be very familiar, become overly familiar and verbally, physically behavior with the strangers. And we have to be not to be confused it with the ADHD impulsivity, because some ADHD kids, when they are very young, impulsive, they just run out onto the street without looking back. But the context of this is really social area. In social engagement, these kids do not differentiate family member versus a stranger, and they can be easily identified that way. Again, the causes are very similar to reactive attachment disorder, the same. They have experienced extremes of insufficient care, neglect, deprivation, or repeated primary caregiver change. And if they have to be at least 9 months of age. And differential, this can be different things like developmental disabilities, autism spectrum disorders, ADHD, and some kids with severe anxiety may have difficulties with the separation problems and their affect and affective regulation. And again, PTSD, of course, early childhood, especially complex PTSD, complex trauma can cause some of these symptoms, and they can overlap. And also there are a couple of syndromes like fetal alcohol syndrome or Williams syndrome. They may have indiscriminate social behavior, so they may be confused with, they can have the symptoms of the disinhibited type. So epidemiology, we have a few data. I can move my box to see the ratio because it's right there, but in infant mental health clinics, it's 1 to 20%. If the children are assessed, if they are in the first 3 months, they are placed in a foster care, it can be 40%. And if there are institutionalized children, I know not in this country, but there are other countries who kids are still being institutionalized in orphanages, they have 75% of this diagnosis. And there are a couple longitudinal studies. If you want to read about, Charles Zena is a big author. He had multiple projects, Bucharest, and also more randomized studies. And assessment is really important because it's good to look at the interaction between child and caregiver, not just one visit, but couple. Detailed history of maltreatment, early environment, and sometimes observation when they play together, or when they separate, how they reunite, that's to check the attachment relationship, or there's a familiar or unfamiliar person, how they react to the parent and the unfamiliar person. Of course, any suspicion, we are all in this field that we report to protect them. And if there are any concerns about their development, there is milestones are not met, it's good to refer them for speech medical screening. And also one important aspect is really important to assess caregivers' attachment to the child, their attitudes, their perceptions, because I have worked with so many parents that when they have their own trauma, it's very hard to help their crying child because it can be their trigger. And treatments not recommended is, as you can see, any restraint, coercion like holding, rebirthing, promotion of regression for reattachment have no empirical support and also associated with serious harm and death. And our academy really warns that. And clinical implications for treatment, first priority is to establish a safe and stable caregiving environment. Treatments that start successfully assessing the relationship between the caregiver and the child. And the first question is whether child has an attachment relationship. If not, the treatment should be establishing one. And if the child has an established attachment relationship, the second important aspect will be the quality of this connection. And the goal is to really enhance the quality and reduce maladaptive qualities. And evidence-based treatments are attachment-based therapies. It could be working through the caregiver or working in the caregiver-child dyad, infant-parent psychotherapy, child-parent psychotherapy. And then the last one is the circle of security, which is done actually group setting with mothers and watching videos using the attachment theory as well as object relationships theory. There are a couple useful pages. I gave you the 0 to 3 and our ACAP. And also, if you click on this, it will take you to the website. This is Circle of Security International Prevention Program for Parents and Children. There's resources for families, mental health agents, workers, therapists. There are resources and trainings for that. So this is the end of my presentation. I'm open to stay with you maybe 5 or 7 minutes before I go to my next presentation. I have a journal club here for the fellows.